For the questions, I think we are going to discuss on the same topic in our first MDT. Shall we leave question because we may clarify certain questions in the MDT?
This moment, I would like to express our sincere appreciation to Dr. Sumana Handagala for his valuable contribution as the chairperson of the morning scientific session. Sir, please remain on the stage for a moment. May I now invite Dr. Niranjan Disanayaka to present the certificate of appreciation to Dr. Sumana Handagala. We now move on to our first multidisciplinary team discussion titled Bronchiectasis in the Young Neglected Entity. To moderate this session, may I invite Dr. Niranjan Chandramal, Consultant Respiratory Physician, District General Hospital, Vavuniya, to kindly come forward and take his seat on stage. Over to you, sir.
Okay, good afternoon, everyone. I think you heard exceptional 4 lectures by now. So it's our renowned specialist. So now we are going to little bit change the gear. So now we are going for a little bit of a live discussion. This is, I think, we named as bronchiectasis in the young neglected entity. So as making a foundation for this, so probably we are going to present a case. So I think today Ms. Afra Nafil, third year medical student from Faculty of Medicine, University of Mortua, she's going to present a very interesting case. So I would like to welcome her for the podium for the session. But before she starts the session, I want to introduce the panelists. So the first panelist is, I think you already know who is. Now I think he did a very excellent detailed lecture about the primary ciliary dyskinesia. So I would like to welcome Dr. Ricardo Jose. He's a consultant respiratory physician from Royal Brompton Hospital, London, and a honorary associate professor in University of London. It is an honor to have him in this discussion. And we would like to join another expert from the genetic assessment side. So I would like to welcome Dr. Dineshni Hettiarachchi into the stage to join us. She's a senior lecturer and deputy director service of Center of Genetics and Genomics, Department of Anatomy, Genetics and Biomedical Informatics, Faculty of Medicine, University of Colombo. And probably we can, I think, have a good discussion about what are the evolving, I think, genetic tests and how we can use that in the management as well. So thank you to accept our invitation. Right, so I think let's move to the presentation. So over to you, Ms. Afra, you can start the presentation.
Thank you, sir. Good afternoon, everyone. It's an honor to be here today, and I would like to thank Sir Dr. Niranjan Disanayaka for giving me this opportunity. And today I'm going to present a case of a young girl with bronchiectasis presented to our routine chest clinic with fever, headache, and chronic productive cough. So initially, I would like to present the clinical history, followed by the relevant examination findings, investigation, and management. So she was a 16-year-old girl from Beruala, and she presented with a complaint of 3 days history of fever, malaise, and chronic productive cough with a sputum of approximately 2/3 of a yogurt cup produced per day. She also complained that she had a difficulty to expectorate the sputum, and she also complained of constitutional symptoms and night sweats. And she said that there was no obvious blood-stained sputum, and also she complained of symptoms associated with bilateral chest pain, and also exertional dyspnea with of MMRC grade 2. In addition, she complained of a right side ear pain and frontal headache and a persistent postnatal drip. So moving on to her past medical history, she had completed a 6 month of antituberculosis therapy for smear-negative pulmonary tuberculosis at her age of 13. And also she is a known patient of moderate persistent bronchial asthma, and she was managed on inhalers. She is also having a chronic allergic rhinitis with a persistent postnatal drip since her early childhood. So moving on to the family history, her family history was remarkable. Her parents were consanguineous, and her paternal grandmother suffered with a chronic productive cough and progressive dyspnea. And her younger brother had also a congenital heart defect, and the other younger sibling had high myopia. So, this raised the possibility of an inherited disorder in this patient too. So moving on to the examination findings. On examination, she was thin-billed, undernourished, and her weight was 34.5 kilograms, height 155 centimeters, giving an BMI of 14.4 kilograms per meter square. And she had digital clubbings, bilateral hands, and also she showed and also on examination we found that she had a left-sided nasal polyp, and she had no peripheral lymphadenopathy. Her respiratory examination was remarkable. She had an oxygen saturation of 95 on room air, 91 on room air, and also on auscultation, she had bilateral cross inspiratory crackles and bronchi. So, cardiovascular examination, she had a palpable apex on the right side of the hemisthorax consistent with dextrocardia. And she had a pulse rate of 64 beats per minute and blood pressure of 96/71 millimeter per mercury. And all other systemic examination was unremarkable. So I would like the respected consultant panelists to elaborate on the radiological investigation.
Right. Okay. So I think we can see I think chest X-ray and X-ray sinus view. So I think I would keep Dr. Jose to describe about the HRCT probably comes in late. So I think in chest X-ray, I think you can obviously see there is a dextrocardia is there, and you can see some dilated like a bronchial tree behind the heart, which is consisting with bronchiectasis. And in the sinus view also, again, you can see there are some bilateral maxillary sinus opacities there. So there are ongoing bronchiectasis, dextrocardia with some sinusitis is going on. Over to you, Afra.
Yeah, thank you. And next, this is the HRCT scan of that patient. Yeah. So before that, I would like to explain the investigation. So her routine blood test, the hemoglobin was normal and her white blood cell count was normal, but she had a mild eosinophilia. And she had a mildly elevated CRP of 6 milligrams per deciliter, and her ESR was 14 millimeter within first hour. She had a normal renal and a liver function test. So, and this is significant. She had a recurrent respiratory chest infection consecutively for 3 months with positive sputum culture. On May, she had a scanty growth of Staphylococcus aureus, sensitive to cloxacillin, clotrimazole, clindamycin, vancomycin, and gentamicin. On June 26, she had a sputum culture positive for moderate growth of Pseudomonas species, sensitive to ciprofloxacin, piperacillin, tazobactam, ceftazidime, meropenem, and nettlemycin and ticagrelin clavulanic acid. On July 2026, she had a sputum culture positive for the moderate growth of coliform bacteria. The isolated species was extended spectrum beta-lactamase producing, sensitive to amikacin, and intermediate sensitive to ciprofloxacin. Her tuberculosis follow-up showed no active disease of tuberculosis. Her echocardiogram showed dextrocardia with no structural abnormalities and no pulmonary hypertension. So yeah, HRCT will be explained by the panelist.
I think we can go to the next slide. Yeah. I think can we just go through the CT, please? Just click on the slide.
Yeah.
So I would like to, Dr. Jose, so I think if you can see the images, if you can comment on about the radiological changes.
Opportunity to be here today with you all. So looking at this CT scan, as it's being scrolled through, you can see that there is situs inversus. So not only is there dextrocardia, but the gastric bubble is also on the right side instead of the left. You can see that there's extensive cystic bronchiectasis in the right lower lobe with mucus plugging. There's also significant bronchiectasis in the lingula, and there's relative sparing of the upper lobes in this patient.
So, Dr. Jose, by looking at the CT changes, so what do you think? What are the differentials in this situation? What do you think about? What are your first priority in when you are thinking about a differential diagnosis?
So I think, looking only at the CT scan, with the presence of situs inversus and bronchiectasis, you need to think about primary dyskinesia as a potential diagnosis, as I've highlighted in the talk. You also have areas of involvement which are seen commonly in patients with PCD, which is the lower lobes less likely, but certainly right middle lobe and lingula are quite commonly seen in PCD. What is sort of missing is that it's quite common to see volume loss in PCD, which you don't necessarily see large areas of collapse or atelectasis in this case. But there's other things we can discuss later on in the history that again would suggest that a diagnosis of PCD needs to be excluded, not only based on the young age, but also the other factors that were very clearly highlighted in the history.
Right. Okay. Over to you, Afra, about continuation of the presentation.
Yeah, thank you, sir. So now next, so according to the professional diagnosis, we came to a diagnosis of primary celiac dyskinesia with Carter syndrome, and genetic tests are planned to be done. And so with the management, once the patient was admitted, she was managed for the acute exacerbation with intravenous culture-sensitive antibiotics, IV ceftazidime, and she was also given chest physiotherapy and airway clearance technique. She was nebulized with 0.9% saline for asymucolitis and for airway humidification. And for asthma management, she was managed with long-acting beta-2 agonist with inhaled corticosteroids, and she was also managed with for chronic rhinosinusitis with intranasal steroid therapy. When she was discharged, she was clinically stable and also hemodynamically stable. And I would, before I conclude, I would like to seek the panel expert opinion for these MTT questions. What are the possible etiology of this patient? Any clues in available clinical details or investigation result? How to prioritize the next investigation? The place in genetic testing and what are the available tests? What are the main considerations on management? And how to prevent the next exacerbation? Thank you.
Okay, thank you, Ms. Afra. I think it's a very good, thought-provoking presentation. So I would like to start this discussion again from Dr. Jose as a pulmonologist and the immunologist as well. So in this, you can join the stage as well. I would like to know, so if you are investigating this patient further, so what are the investigations you would like to add to the available investigation, and how to prioritize the investigation? Because what of the problems in the middle and low income countries are the limitation of the investigation, especially like conditions like primary ciliary dyskinesia and some immunodeficiency disorders. So what are the investigations we can prioritize?
Okay. So I think it's obviously important to focus on obtaining a diagnosis, but clearly in this young patient, the importance of treatment in some ways precedes diagnostic capabilities, because you want to protect this patient's lungs from further bronchiectasis progression and lung function decline. So I'd focus on that. Then going on to treatment and for investigations, I think a clinical diagnosis of PCD is highly likely based on a few factors. So you have someone who's young with bronchiectasis, which is severe. You have someone who is presented also with a history of chronic rhinosinusitis and an acute sinusitis with fever and congestion of the nasal sinuses. You have someone whose history includes consanguinity relationship with the parents, family history of cardiac abnormalities in sibling, and you've got the laterality abnormality with situs inversus. So clinically, I think it's a high probability case of PCD, and if genetic testing is available, I think it's very useful. But as I mentioned in the talk, none of these tests are going to be always helpful because you do get negative results when someone has a high probability of PCD and actually has PCD. So it's about combining tests. And I think if you focus on genetics, I think that is something that is more likely to give you a result with a diagnosis of PCD, provided your panel includes the 60 known mutations and is not a limited panel based on the more common local genetic findings in Sri Lanka. In terms of immunodeficiency, I think I couldn't see in the presentation what was reported as the total immunoglobulin level, but certainly looking at a full blood count for lymphocytes levels, if they're low, they may suggest a lymphopenia with a reduction in B or T cell counts. And then the total immunoglobulin G, A, and M at the age of 16, so anyone over the age of 5 would be able to alert you to the presence of any hypogammaglobulinemia, which would then allow for further testing. Now, you can do genetic testing as well for immunodeficiencies. In a case like this, I would first focus on identifying objective markers of a diagnosis of PCD, rather than doing genetic testing for rare causes of immunodeficiency. The fact she's had TB doesn't suggest she's immunodeficient in a country with a high incidence of TB. Certainly, you'd want to exclude HIV in this patient, again, mainly because of the history of TB, but also very, very low BMI. One of the things you have to think about is, why does this person have a failure to thrive? What's their height? Did they grow at the appropriate rate during their childhood? Is the BMI just low because they had tuberculosis 3 years ago and therefore they lost a lot of weight with that, which they haven't been able to gain back post-treatment for TB because they've got ongoing respiratory disease? Because one of the things that could come out of this case is that this could be related to a post-infectious cause, which was the tuberculosis. So it would be very important, which wasn't presented in the case, to know what did the imaging and the CT scan look like at the time of diagnosis of the tuberculosis, because if it showed, obviously, the situs inversus that she was born with, but it shows no evidence of bronchiectasis elsewhere, and maybe just stain consolidation in a upper lobe, or even a lower lobe in terms of primary tuberculosis, then post-infectious actually becomes a more likely reason why they've developed bronchiectasis. So I think going back through the history is important. What was her childhood like? Early childhood as a baby, infant, toddler? Did she have ear infections? Did she have sinus infections? Was she having recurrent chest infections at that point? Or did everything come on after this diagnosis of tuberculosis?
Right. I think, thank you for your excellent answer, Dr. Ozzy. So I think I would ask another question a little bit out of the box from the primary ciliary dyskinesia, because if we found a patient with like a young bronchiectasis patient in the clinical history, so what are the specific things in the history examination and the initial investigation? What are the specific things you have to consider more about identify the etiology. Anything like as an example in a cystic fibrosis or any like a common variable immunodeficiency, any clues coming in the history and the examination and the initial clinical investigations.
Yeah, so I think those conditions are all associated in childhood with a failure to thrive, a failure to grow at the appropriate rate or maintain an adequate weight. So looking at those things is important. It's very important to look at what's happened around the time of birth. So, for example, we know that patients with PCD and cystic fibrosis can have respiratory distress at the time that they were born. They may require a stay in the neonatal intensive care unit or HDU. We also know, for example, in CF that there's usually meconium at the delivery, so that again would highlight that as an issue. The early infections in childhood is important. Now, in patients with cystic fibrosis, they don't tend to get the recurrent ear and sinus infections usually, but they do during PCD. And then as the child's growing up and having recurrent infections, I think it's important also to look at the pathogens that they grow in and what you are treating. Initially, you find the infections with Staphylococcus aureus, Haemophilus influenza. Later on in life, you get bacteria such as Pseudomonas. With some of the immunodeficiencies, for example, the polysaccharide antibody deficiencies, you will find the infections more likely, or even with the CPID, hypergammaglobulinemia, with encapsulated organisms. So not necessarily Pseudomonas, E. coli, Klebsiella. It's the Haemophilus, the Streptococcus pneumoniae, the Neisseria meningitis. Those kind of infections would alert you to be thinking of those conditions. So I would go back at finding out what happened at the time of birth and how did things develop from there up until the time of the diagnosis. Radiologically, currently with the bronchiectasis, it does spare the upper lobes. That makes cystic fibrosis radiologically less likely. But none of these things are set in stone, and you can't say just because there's no right upper lobe or left upper lobe involvement that this isn't the case of cystic fibrosis. I just think when you're talking about probabilities, everything else put together, as you've mentioned, with the consanguinity, the brother having cardiac defects, the sinus and ear infections, the situs inversus, that all points towards the provisional diagnosis you've made clinically.
Okay, thank you, Dr. Jose. So I will come back to you to discuss regarding some management points as well. So I'll move to Dr. Dineshani about, I think, because there are now things I think we discussed about what is the importance of the genetic testing, whether we can do that, because in the Western world I think it is freely available, but our limitation is it's the very limited availability and the cost as well. So I would like to know, I think, what is the role from the genetic testing wise for the cases like in bronchiectasis and the other respiratory diseases? We know in the lung cancer we already now started the things, but how in the other respiratory diseases?
Thank you very much for having me here today and also for the question. So genetic testing is currently being available and made available progressively as we talk about multidisciplinary care, because a lot of conditions has a genetic etiology as we look at different multidisciplinary areas as well. Particularly to this case, primary ciliary dyskinesia. So when I sort of read about the primary ciliary dyskinesia, in addition to the 16 genes Dr. Jose mentioned, there are about 55 genes that we can sort of target when we look at the primary ciliary dyskinesia alone. So majority, about 33% of primary ciliary dyskinesias are due to this dynein protein that is essential for the function of the ciliary motion. So the simultaneous ciliary motion, which is impaired due to these particular genetic variants. So right now, as Dr. Jose also mentioned, we don't do the panel testing here because panel testing is restrictive and we only look at certain only few genes. So within these genes, there are about 2,000 mutations specifically for primary ciliary dyskinesias. So we now go towards more of whole exome sequencing, where we look at the entire protein coding region in the genome. So that way we don't miss anything. So even if it's not a primary ciliary dyskinesia, it could be a different pathology, we can still, get a diagnosis. The diagnostic yield is more when we do a whole exome sequencing or even a whole genome sequencing. So as you mentioned, the cost is a factor, right? So whole exome sequencing at the faculty, we offer at 125,000. Before the financial crisis happened, the government used to sponsor that. So we had a circular for rare diseases where hospital directors could fund certain investigations, and the whole exome sequencing was a part of that cocktail of investigations that they could order. Unfortunately, because of financial constraints, now only the karyotype and other basic genetic investigation is state funded. But I think with the awareness growing, and even if we have a research grant, that way we can offer these tests at a nominal cost or even free of charge to patients. So again, coming to this case, primary ciliary dyskinesia, majority of them is autosomal recessive in inheritance. There are few autosomal dominant and few X-linked. So as you said, it was a consanguineous marriage, and also the grandmother had. So this has a very positive history, and I think this would warrant a genetic testing, and I think we might be able to diagnose this condition through genetic testing also.
So, thank you, Dr. Dinesh. So the other question is about, because of the limited availability, how to prioritize the patients, and what is the pathway to referrals? Because I think I think most of the clinicians will want to know about how to refer a patient as well. So I would like to know about that as well.
Yes, so as you mentioned, we have the cancer arm and also we have the rare disease arm at the faculty. So rare diseases, we have so far sequenced about 1,000 different rare diseases. So when I looked at the database, we had about 25 conditions referred to us through because of lung pathology. So out of that, it was cystic fibrosis was one condition. The other one was primary ciliary dyskinesias, bronchiectasis, and the others were the syndromic causes. So I think prioritization comes through the experts. So if a pulmonologist thinks, okay, this has a very good suspicion of being genetic, then they refer to us, where we do a evaluation and see whether, okay, can the patient, go ahead with the treatment? Can the patient afford it? Or is there another pathway where we can get the patient into a study that we are currently doing and offer the test free of charge? So after an initial evaluation by a clinical geneticist, we do the investigation. So after the investigation report comes, if it's a whole exome sequencing, we do a post-test counseling session before we release the report. And in terms of how do you prioritize, especially cystic fibrosis, now we have modulator therapy like Trikafta. So in that particular condition, yes, it makes a lot of sense to do the genetic evaluation. But I think having a genotype done is very essential, especially if we are planning to do research or if the therapies are coming to the forefront in the future, especially like alpha-1 antitrypsin deficiencies where augmented therapy is available. So I think primary ciliary dyskinesia, currently there is RNA editing pathways that they are discussing, which is in clinical trials. So maybe if there are what happens is if a university or organization is doing clinical trials, they reach out to us and say, okay, do you have patients that carry this particular variant? So if we do have, we can then give those information to that clinical trials committee so that these patients can benefit from if there is a drug available. So that is how the system works. So if we genotype, it is beneficial for us as a nation as well as the patient as well.
Okay. Right, thank you. So I would like to move on to again Dr. Jose for asking about few points about the management. So so if you want to manage this patient, I think with the available, I think you already see what are the management that the we have done, what are the things you want to add into this management? I think in the sputum, you can see there are some 3 cultures with positive, one again a moderate growth of Pseudomonas. So what are the other, your suggestions about the management on this patient?
Thank you. So in terms of the treatment, if you're focusing on the bacteria isolated and giving the intravenous antibiotics, in a young person, if this was the first known isolate of the Pseudomonas, I would have given the prolonged course of IVs of 10 to 14 days, ideally 14, and most likely followed that through with 3 months of nebulized colonomycin, aiming to eradicate the pathogen, because we know the earlier we tackle that, the most likely the better outcome the patient will have, other than allowing it to develop colonization. Airway clearance is highly important and the mainstay of this bronchiectasis treatment. So you want to relieve as much mucus out of the lungs. It will help with pathogen clearance as well. We believe that reducing mucus in the airways will hopefully reduce inflammation, which over time may reduce the amount of mucus being produced. So I would focus on an airway clearance regime that the patient can do that's effective for them, and encourage them to do that. Again, they've got sinus disease, so I would focus on nasal sinus irrigation. They've got polyps, so I would want to use anti-inflammatory topical steroids in the nose to try and reduce negatively the size of those polyps. And I would consider obviously an ENT review of the nasal passages and assessment of urine, particularly as I mentioned in the talk. Hearing impairment during childhood and early adolescence will affect communicate and the education, so tackling that is important. And note I made is her diagnosis of asthma and allergic rhinitis. Now, then obviously got nasal polyps, so that's most likely due to an allergic rhinitis or type 2 inflammation. But I would want to make sure that the asthma diagnosis is correct. A lot of patients get diagnosed in childhood with asthma and even adult bronchiectasis patients with COPD, for example, because they have obstructive airflow and lung function, but they don't actually have those conditions. It's down to the bronchiectasis and the muco-obstructive lung disease causing those lung function changes. And we don't want to be treating people with inhaled corticosteroids if they don't need it. So I would want to make sure that the diagnosis is made correctly by checking that they do have reversibility of greater than 12%, that they do have a raised nitric oxide suggesting type 2 airway inflammation, or they have a positive methicillin challenge test. And I wouldn't just assume a priori that the diagnosis made in childhood of asthma was correct. I'll be looking for evidence. And then as the patient shows a lot of mucus plugging and mucus in the scan, I'll be asking questions about the mucus viscosity, how easy it is for them to clear the chest with appropriate physiotherapy. And if it's not, I'll be adding in the mucoactive agent. So probocysteine, N-acetylcysteine, hypertonic saline, to try and improve their airway clearance. And then finally, again, for all patients with bronchiectasis, I particularly, once we've excluded the immunodeficiencies, I would be looking at the pneumococcal antibodies. Do they need a booster pneumococcal vaccine? Recommend the annual influenza vaccine. In older patients or very young patients, I also usually recommend the RSV vaccine. So those are the kind of things we'd be talking about, and certainly counseling patients on not smoking, avoiding biomass fuel exposure, things like that.
Right. Okay, I think, thank you, Dr. Jose. I think you have given a very explanatory answer for that. So I would like to ask if there's any burning questions from the audience as well. I think Dr. Amita Fernando is there, so probably I would note you.
Thank you, Dr. Jose, for a very interesting discussion and also a detailed presentation on PCD. My name is Amita. I'm a senior consultant chest physician at the National Hospital. My question was, as you mentioned in detail about the nasal polyps and whether we should query the history of asthma, whether these should be validated looking for Th2 type of inflammation. We know that 5 to 10% of patients with cystic fibrosis get ABPA. How closely is there, from your experience, is there any data on PCD and ABPA? Should we be looking at the HRCT in more detail for mucus plugs, as you mentioned, and high attenuated mucus? Do you think that is there any association with PCD and ABPA?
Yes, there is. So we've got, I don't know the exact number, but we certainly have a few patients in our clinic with primary dyskinesia who also have allergic bronchopulmonary aspergillosis. So yes, we would be looking at CT scan for bronchoseals, high attenuation mucus, more central bronchiectasis as well in these patients. But usually the clue comes through the biochemical testing. So we would find very high total IgE, greater than 1,000, greater than 500, and a specific aspergillus IgE that's positive, or skin prick test that's positive, suggesting sensitization. So like CF, like asthma, PCD also has that association with ABPA. I think people who have structural lung disease are more prone to developing ABPA because they don't clear the aspergillus spores that are being inhaled on a daily, regular basis, and therefore are more likely to become sensitized over time. So certainly we would be looking for that, and that's a good point to raise. And certainly, again, because of access to testing, when we get a new bronchiectasis patient, we always do the aspergillus IgE, total IgE, the IgG, AN. We check for alpha-1 antitrypsin deficiency. We look for low pneumococcal tetanus antibodies. So we'd be looking at all those parameters in every new diagnosis to try and increase the yield of identifying causes and not labeling everything as idiopathic.
Any other questions from the audience? So there is one online question is there. So I think coming from the Dr. Jose, what is the place for the pulmonary rehabilitation in this kind of patient?
Yeah. So again, a very good question, because with all our patients who have progressive disease and lung function decline, there is worsening breathlessness. And we know that with worsening breathlessness, you get deconditioning, and that has a negative impact on the perception of breathlessness as well. So similar, although there's not aware of any specific study in PCD, similar to patients with COPD, there's likely to be benefit from pulmonary rehabilitation. So when I've got patients with lung disease, structural lung disease, who have breathlessness, including our PCD patients, particularly the older population, I do encourage, as I mentioned, exercise, and with that comes in pulmonary rehabilitation. And I must say, from the perception I get from patients with bronchiectasis and PCD going for pulmonary rehabilitation is that they do find it helpful. And following the training, they are encouraged to continue the exercise at home, and if needed, re-enroll in pulmonary rehabilitation after a year or two.
Right. Thank you. I think one question for the Dr. Dineshani about I want to know about what is the, I think, in future in the genetic testing in Sri Lanka, and whether what is the place at the moment for the like a genetic counseling as well. And with that, I want to because as we are going to the end of this MDT, I want to get your just a single message for the our clinicians and the respiratory physicians about what you want to deliver as a single message to us.
Thank you. So, as a benefit, I think I didn't mention this earlier, but we can do something called family member screening. How we do it is, if somebody has a overt condition, like they have the symptoms, we usually screen that person first. Then once we identify the pathogenic variant, then we can only sequence that Sanger sequencing, we call that sequencing. We only do that particular variant in the family members. So this is what we call cascade screening. So we don't have to spend 125,000 for each person in the family. So the cost will be much less. So again, family member screening is a benefit for the patient's family, and also we can do reproductive counseling. So if somebody is a carrier of a pathogenic variant, then if it's an autosomal recessive condition, then we can see whether the partner also carries the same variant and do the reproductive counseling as such. How do I see the future? So future is precision medicine. It's coming in all sort of specialties. Precision medicine is being talked about very openly now. So when we talk about precision medicine, it is personalized medicine. So when we talk about personalized medicine, again, the genotyping, all of that comes to play. And if I give one message, is that the basic genetic tool that every doctor has is the family tree, the pedigree, 3-generational pedigree. So I think that will give you a clue if that is a heritable condition. So if you can draw a 3-generational pedigree in every patient, I think you will sort of narrow down what are the genetic conditions in your practice. So that is my final advice to everybody.
Thank you, Dr. Dineshani. So, as a last question from Dr. Jose, I would ask the same question from you. What is the single message so you are going to give our clinicians in Sri Lanka regarding managing bronchiectasis, and especially this kind of patients with young bronchiectasis?
So I think for now, particularly in the absence of specific disease modifying treatments or curative treatments in bronchiectasis and PCD outside of the context of cystic fibrosis, I would focus on getting the basics right, as I mentioned in my talk. We want to limit progression of disease, declining lung function, reduce exacerbations, and improve people's quality of life. So we need to focus on making sure that patients are having appropriate and effective airway clearance, that we're treating infections early, that we are identifying those with frequent exacerbations and using currently available and cheap immunomodulatory therapy such as azithromycin, which has been shown in various clinical trials in bronchiectasis and PCD to have positive outcomes. There's no point in thinking about, well, I need to get the new expensive drug that's coming out for bronchiectasis when the basics haven't been done correctly. And I think if we're doing the basics correctly, we can really help our patients and then put the cherry on top with new treatments when they become available and they are cost effective. So that would be my message. Get the basics right of the treatment and make sure your diagnosis is correct. We don't want to be causing harm by, for example, treating asthma and things like that when they are not existing.
Right. Thank you, Dr. Jose. I think now we are coming to end of a very interesting case discussion. I think we have discussed about more points about the treatment of the bronchiectasis and the management and the prevention of the exacerbations as well. And I would like to thank all the panelists, Dr. Ricardo Jose and Dr. Dineshani Hettiarachchi, about taking your time and sharing your expert knowledge to us. And I would like to congratulate Miss Arfa as well. So as a starting your career, I think you are getting a good experience presenting in this kind of a postgraduate exercise. So, and thank you everyone, and over to you now to continuation in the next MDT. Thank you.
Our sincere thanks to Dr. Ricardo Jose, Dr. Dineshani Hettiarachchi, Dr. Niranjan Chandramal, and Ms. Afra Nafil for their invaluable contribution to this excellent multidisciplinary discussion. I would now like to invite Dr. Niranjan Disanayake to kindly present the Certificate of Appreciation to the resource persons of this session. Dr. Dineshani Hettiarachchi. Dr. Niranjan Chandramal, Ms. Afra Nafil. I would also like to invite the resource persons of this MDT discussion to kindly remain on stage for a moment for the official photograph.